inline neb than CPAP. You guys already got the CPAP. You guys already know the BDM. It's pretty basic, right? The main idea behind this, now, I'm going to preface this with, when you do your rides, when you do your internship, know what your agency has. There's a few different CPAPs out there in different configurations. There's a couple things that are consistent throughout, and that's what I'm going to go over. But as far as what adapters fit to what CPAPs and what you need, that's going to be determined on what system your agency uses. So that would be one of the top priorities for me if I'm doing a ride along, is figure out what your agency has and ask how to set it up. But the biggest thing, so if you're setting up your CPAP with your inline neb, the biggest thing is to have your adapter going to, do you guys have the 15 to 22 millimeter adapter? Another one of these? Okay. So, this is kind of the setup. Do you guys know the liters per minute of O2 going here?
It'll be open, right? So
It's kind of just open, right? If you're on your Christmas tree, where the Christmas tree is on your wall mount, you're going to pull the Christmas tree off and screw this in. Okay? On a lot of the portable oxygen cylinders, there's another port that you can just screw this in, and it's just on or off. You can't dial up the flow like if you plug in a cannula or oxygen tubing to it. So it's pretty much on or off. This dials in your centimeters of water, 5, 7.5, 10. Okay. What I will tell you is, for school and testing purposes, start at 5, evaluate your patient, O2 sat, skin signs, work of breathing, and then if needed, dial that up. There's a spring in here that, as you tighten this, it increases the amount of pressure that's going in. Okay? So whatever this arrow is pointing to is what you're flowing. Are you guys all semi-familiar with this? Okay. So start with 5. Now, you have this connection, right? What is the liters per minute for this?
4 to 6.
6 to 10. 6 to 10. Start with 6. Evaluate the effectiveness of your medication, and then adjust it accordingly. Okay? And then this is going to go to your CPAP, right? And there should be another adapter. Actually, okay? So, like I said, this connection is a little bit different. You're going to need different adapters, whatever you need. So, just know what we have, what my agency has, is one Ziploc bag with everything that I need to connect to an ET tube and the nebulizer and everything. So all I need to do is open that up and plug it into my ET tube. It's all set up, it's all ready to go in a bag. Then separately, in another Ziploc bag, there's another one set up to plug into a CPAP. So there's no thinking on a call. That's done prior to the call, that you have it all set up so you can just plug it together and get moving, because these patients are typically really sick and you don't want to have to think about what adapters to grab and where to find them when you're in the middle of it. So 6 to 10, start with 6, adjust it as needed. Now with that, I will tell you, so that's book, that's class, right? When you get out in the field, evaluate how this is working. How are we going to evaluate that? What are some ways that we're going to see?
Respiratory effort by the patient.
Okay, so that's kind of downstream. That's a later effect. What can we do right now? Misting, right? So what I have personally noticed with this all the way up, this at 6 to 10, this, if somebody's breathing at 26, 30, 40, 60 times a minute, which is common for a respiratory call, they're going to be breathing too fast to create back pressure to allow this chamber to fill up with aerosolized medication, right? This pressure coming in, this volume coming in, is going to override that, and they're going to get mainly oxygen, and it's kind of knock this medication back down. It's going to try to aerosolize, but then it's going to knock it back down, because this volume is so much more than this, okay? So the back pressure, they breathe, stop. Every time they stop, this chamber is filling up with aerosolized medication. When they take a breath, it clears that. So if they don't give that time to that back pressure, time to fill up with aerosolized medication, they're just breathing. They're just breathing oxygen, which is good for them, but they're not getting any medication. So my recommendation for you, and I spent a lot of time in the ambulance checking this out, when you set this up on a ride-along or the beginning of your internship, hook all this up, throw some saline in there, change your airflows. Turn this one down to maybe 20, dial it down to 20, 15, and then turn this one up 12, 15 liters per minute. See if you can find that mix, and you can put your hand over this to simulate your back pressure. And you can do like a respiratory rate, take a breath, back pressure, take a breath, and see how much mist you're getting. Does that make sense? That's my recommendation, is figure out what works, go through it. You guys have already done CPAP, but just to reiterate, what's 10 going to be used for? What pathological process are we typically going to move to? CHF, right? What would 5 be used for?
COPD.
Okay.
Because it's a low respiratory hypoxygen. They're
Yes.
fragile in their viewing.
Yes. Hypoxic drive, yes. In 12 to 24 hours, if your transport is to Colorado, yes, you can knock out their respiratory drive. For what we use it for, here in San Diego, 20 minutes, we're with the patient, we're not going to knock out anybody's respiratory drive. Nurses will give you a hard time. I'm not going to knock out their respiratory drive. So don't worry about that too much in the field. It's a consideration, but not that likely. What I'm worried about when I do this is how much elasticity their lungs have. If I start cramming oxygen down into them, do their lungs have the ability to expand, like all of us in this room? Our lungs could take it. But somebody that's been a smoker for 40, 60 years, their lungs probably won't be able to expand and accommodate that extra oxygen or that extra volume, and they might blow along, have a pneumo. So keep that in mind. Start with 5, move up. In the field, I typically, if my assessment has determined that this patient is a CHF patient, I'm going to start at 10. And I'm just going to go straight to the max because I'm trying to force that oxygen or that fluid out, and I'm very aggressive with these patients. So I'm going to let you guys get hands-on with this and kind of see what adapters are necessary. I'm sure you guys already did it. But get hands-on with it. What I will say is, and this is my experience, be aggressive with respiratory. There's not many calls that we go on that somebody's talking to you, kind of pleading for help, and then they die in 5 minutes. And I've had probably 3 to 6 that have done that, and it's a terrible feeling for me. Talking to somebody and then all of a sudden they're dead. So if you see somebody working to breathe, be aggressive with it. Get oxygen on them quick, get CPAP on, start treating them with meds. Be very aggressive because these people go downhill very quickly. And it's not a good feeling when you get done with the call and think about it. Because after every call you should be evaluating what you did right, what you did wrong, what you could do better. So thinking about it and going, man, I was talking to that person, then they were dead before we hit the ambulance. It sucks. So anyway, be aggressive with it. So go ahead and get your hands on it.